Hello, I'm Professor Sims, and in this video I will discuss the axial skeleton. This is the fifth in a series of 10 lessons held as part of my Anatomy and Physiology 1 course. If you're a student currently enrolled in this course, please consult the syllabus and course Moodle site for assignments, quizzes, due dates, and other course information. In this unit, we will learn about the functions of the skeletal system and define its two major subdivisions. We'll identify the bones and bony structures of the skull, the cranial suture lines, the cranial fossae, and the openings in the skull. Next, we'll discuss the vertebral column and regional variation in its bony components and curvatures. We'll describe the components of the thoracic cage, and finally, we'll discuss the embryonic development of the axial skeleton. The skeletal system serves as the structural framework of the body, encompassing bones, cartilage, and ligaments. Its primary role is to provide support, shaping the body and facilitating various movements. In adults, the skeletal composition comprises 206 bones, with a higher bone count in youth due to fusion during childhood. The skeleton's essential functions include offering rigidity for supporting the body's weight against gravity and providing the necessary structure for muscle actions and overall body movements. The lower skeleton is specialized for stability during activities like walking or running, while the upper skeleton grants greater mobility, enabling actions such as lifting, carrying objects, and facilitating movements of the head and trunk. Beyond its structural functions, the skeletal system plays a crucial role in protection and storage. It safeguards internal organs such as the brain, spinal cord, heart, and lungs. Additionally, the bones serve as primary storage for essential minerals like calcium and phosphate, while the bone marrow housed within supports fat storage and the production of blood cells. The two major subdivisions of the skeletal system are the axial skeleton and the appendicular skeleton. The axial skeleton forms the central axis of the body, and it consists of bones in the head, neck, chest, and back. Components of the axial skeleton include the skull, which has 22 bones, an additional 7 bones associated with the head, the vertebral column, which has 24 vertebrae, the sacrum, and the coccyx, and the thoracic cage, made up of 12 pairs of ribs and the sternum. The axial skeleton provides protection for vital organs and serves as attachment sites for muscles involved in moving the head, neck, back, and limbs. Complementing the axial skeleton, the appendicular skeleton includes all of the bones of the upper and lower limbs, along with those attaching the limbs to the axial skeleton. In adults, the appendicular skeleton consists of 126 bones, and we will be covering those separately in the next chapter and in the next lesson. Figure 7.2 shows both the axial and appendicular skeleton. For this lesson, we are going to focus just on the axial skeleton, which is part of the skeletal system that supports the head, neck, back, and chest, and thus it forms the vertical axis of the body. More specifically, we will be looking at the bones of the skull, the vertebral column, and the thoracic cage, formed by the ribs and the sternum. In Lesson 6, we will discuss the appendicular skeleton that includes bones of the upper and lower limbs. The cranium, or skull, serves as a support structure for the face, and it also safeguards the brain. It is anatomically divided into facial bones and the brain case, also known as the cranial vault. In adults, the skull is composed of 22 individual bones, with 21 of them forming a cohesive and immobile unit. The mandible, or the lower jaw, is the only bone of the skull that is capable of movement. When you're looking at the anterior view of the skull, you're going to see the facial bones that provide structural support for the eyes and other facial features. The orbits house the eyeballs. The nasal cavity structures contribute to the formation of the nasal septum. Passages for sensory nerves are facilitated through the supraorbital and infraorbital foramina. The lateral view of the skull shows the significant brain case above, with upper and lower jaws containing teeth below. The zygomatic arch serves as a separator between the brain case and the jaws, and the temporal fossa and intratemporal fossa house multiple muscles that are responsible for the movement of the mandible during chewing and speaking. Figure 7.4 shows the bones that form the forehead, orbits, nasal cavity, nasal septum, and the upper and lower jaws. We are going to discuss several of these bones in more detail. For example, the frontal bone, the lacrimal bone, the nasal conchae, and all of the other bones of the face. We'll talk about those some more in just a moment. For now, let's look at figure 7.5. This is the right lateral view of the skull. And here you can see the large rounded brain case. You have the zygomatic arch, zygomatic process, the upper and lower jaws. So this here is the mandible, and you have the maxilla. Here you can also see the occipital bone, the mastoid process, ethoid bones, frontal bone, parietal bone, temporal bone by the temples, the styloid process, which is just under here, and several cranial sutures that we will discuss in more detail momentarily. The bones of the brain case ensure the protection and containment of the brain. This region is defined by the cranial cavity, the calvaria, which is the skull cap, and various flat bones that contribute to its structure. The base of the skull is divided into anterior, middle, and posterior cranial fossae. Each bone of the brain case has its own role and characteristics. The parietal bone, situated on the upper lateral side, forms connections with the frontal, temporal, and occipital bones. The temporal bone, found on the lower lateral side, is subdivided into regions with distinct landmarks. The frontal bone shapes the forehead and features the glabella and supraorbital margin. The occipital bone constitutes the posterior skull and base, housing the external occipital protuberance and the foramen magnum. The sphenoid bone, a central keystone bone, plays the role of forming the base and sides of the skull, and the ethmoid bone contributes to the roof and lateral walls of the upper nasal cavity, nasal septum, and the medial orbit wall. Figure 7.6 shows the bones of the brain case. The cranial cavity, shown here at the base of the brain case, is divided into the three cranial fossae, anterior, middle, and posterior, and each of these fossae contains a specific region of the brain. Shown here are the frontal lobe, the temporal lobe, and the cerebellum. Skull sutures are immovable joints that tightly connect adjacent bones of the skull, enhancing the skull's strength and capacity to protect the brain. The coronal suture unites the frontal and parietal bones, while the sagittal suture connects the right and left parietal bones. The lamboid suture joins the occipital, parietal, and temporal bones, resembling an inverted V shape. The squamous suture interconnects the temporal and parietal bones, and the pterion, a weak region formed by the intersection of frontal, parietal, and temporal and sphenoid bones, is the most vulnerable part of the skull. The facial bones of the skull comprise 14 bones in total from various structures such as the upper and lower jaw, nose, nasal cavity, septum, and orbit. And among these are the 6 paired bones, including the maxilla, palatine, zygomatic, nasal, lacrimal, and inferior nasal conchae bones, along with 2 unpaired bones, the vomer and the mandible. Additionally, the ethmoid bone contributes to the nasal septum and the walls of the nasal cavity and orbit, and each facial bone serves a distinct function. For example, the maxillary bone that forms the upper jaw and hard palate, the palatine bone that forms the lateral walls of the nasal cavity, the zygomatic bone that forms the lateral wall of the orbit, the nasal bone supports the base of the bone, the lacrimal bone forms the anterior medial wall of the orbit, the inferior nasal conchae project into the nasal cavity, the vomer bone forms the posterior inferior part of the nasal septum. The mandible, which is again the only movable bone of the skull, forms the lower jaw, and it articulates with the temporal bone to create the temporomandibular joint. Lastly, the orbit serves as the bony socket for the eyeball, and it contains muscles responsible for eye movement and eyelid function. With contributions from 7 skull bones, the nasal septum, formed by the ethmoid and vomer bones, and the nasal conchae, bony plates projecting into the nasal cavity, complete the intricate facial bone structure. Figure 7.9 shows the posterior view of the skull and its attachment sites for muscles and joints that support the skull. You also can see several of the sutures. You have the lambdoid suture here and the sagittal suture up here. You can see the occipital condyle, the external occipital protuberance, the temporal bone, the mastoid process from posterior view. Figure 7.11 on the right here shows the sagittal section of the skull and the parts of the nasal septum. So this is like a cross section if you were to cut the skull in half, and you can see the nasal concha, sphenoid sinus, sphenoid bone, nasal bone, the frontal sinus. Also down here, we'll talk about in a minute, is the hyoid bone. Figure 7.18 shows the paranasal sinuses, which are air-filled spaces, each named for the skull bone it occupies. So the most anterior is the frontal sinus, located in the frontal bone above the eyebrows. The largest are the maxillary sinuses, located in the right and left maxillary bones below the orbits. The most posterior is the sphenoid sinus, located in the body of the sphenoid bone. The ethmoid air cells are multiple small spaces located in the right and left sides of the ethmoid bone, between the medial wall of the orbit and the lateral wall of the upper nasal cavity. And here we have the hyoid bone shown in figure 7.19. This bone is not technically part of the skull, but it's included here because it's located in the upper neck and it doesn't join with any of the other bones in the body. In fact, the hyoid bone is the only bone in the human body that does not articulate with any other bone. And it is a U-shaped bone located between the lower jaw and the thyroid cartilage, and it serves as an attachment point for several muscles involved in swallowing and speech production. And it also plays a role in supporting the tongue and helping to maintain the shape of the upper airway. The vertebral column, also known as the spine, it's like a flexible rod made up of interconnected vertebrae. These vertebrae are separated by squishy discs that act like cushions. Imagine it as a series of building blocks stacked on top of each other with soft pads in between them. Initially, there are 33 vertebrae, but as you grow older, some of your vertebrae fuse together, leaving you with 24. These vertebrae are divided into sections. The neck section is cervical vertebrae. The mid-back is the thoracic vertebrae, and your lower back are the lumbar vertebrae. And then below that you have the sacrum and the coccyx, the tailbone. The vertebral column is characterized by curvatures, including primary curves like the thoracic and sacrococcygeal curves, and secondary curves such as the cervical and lumbar curves, which develop postnatally. Each vertebrae has a body, arch, and various processes sticking out of it. Depending on where they are in your spine, they will have different features. Your cervical vertebrae have a bifid spinous process, or a split in the back, as well as transverse foramina and other specializations that we'll talk about some more in a moment. Thoracic vertebrae, the ones in your chest that have larger bodies, they have downward angled spinous processes and facets for rib attachment. Lumbar vertebrae, those in the lower back, are even larger and stronger, and that allows them to support the weight of your body. The sacrum, formed by the fusion of 5 sacral vertebrae, assumes a triangular shape and supports the weight-bearing portion of the spine. And the coccyx, formed by the fusion of 4 coccygeal vertebrae, completes the vertebral column. Intervertebral discs, comprising annulus, fibrous, and nucleus fossa, play a crucial role in providing padding between the vertebrae, and this allows for flexibility and movement as well. Vertebral ligaments, such as the anterior longitudinal ligament, the supraspinous ligament, and ligamentum flavum, contribute to the overall support and stability of the vertebral column. Figure 7.20 shows the adult vertebral column with its 24 vertebrae, plus the sacrum and the coccyx down here all the way at the bottom. The vertebrae are divided into the cervical, C1 through C7, thoracic, T1 to T12, and lumbar L1 to L5 regions. The column has two primary curvatures, two secondary curvatures, and we'll go into greater detail about those in just a moment, but let's first have a look at this overview video first.
The spinal column, or backbone, is one of the most important parts of your body. It provides the main support, allowing you to stand upright, bend, and twist. 33 individual bones interlock with each other to form the spinal column. The vertebrae are numbered and divided into regions. C1 through C7 cervical vertebrae form your neck, support your head and neck, and allow you to nod and shake your head. T1 through T12 thoracic, that's the 12 vertebrae that are joined by ribs to form your rib cage. L1 through L5 lumbar, your 5 sturdy lumbar vertebrae carry most of the weight of your upper body and provide a stable center of gravity when you move. 5 vertebrae of the sacrum and 4 of the coccyx are fused. It makes up the back wall of your pelvis. Between each of the movable vertebrae is located the intervertebral disc. Intervertebral discs consist of a thick outer layer with a crisscrossing fibrous structure, annulus, that surrounds the soft, gel-like center, the nucleus. Discs function like shock-absorbing springs. The annulus pulls the vertebral bodies together against the elastic resistance of the gel-filled nucleus. When you bend, the nucleus acts like a ball bearing, allowing the vertebral bodies to roll over the incompressible gel. Each disc works in concert with 2 facet joints, forming a spinal motion segment. The biomechanical function of each pair of facet joints is to guide and limit the movement of the spinal motion segment. The surfaces of the joint are coated with cartilage that helps each joint move smoothly. Directly behind the discs, the ring-like vertebral bodies create a vertical tunnel called the spinal canal or neural canal. The spinal cord and spinal nerves pass through the spinal canal, which protects them from injury. The spinal cord is the major column of nerve tissue that is connected to the brain and serves as an information superhighway between the brain and the body. The nerves in your spinal cord branch off to form pairs of nerve roots that travel through the small openings between your vertebrae, intervertebral foramens.
As we saw in the video, each vertebra has a body and a bony arch. From this arch, you'll find various processes sticking out. The transverse, spinous, superior articular, and inferior articular processes. Inside the arch, there's a hole called the vertebral foramen where the spinal cord passes through. Between each pair of vertebrae, there's another opening, vertebral foramen, where spinal nerves exit. Intervertebral discs unite the bodies of adjacent vertebrae. Think of the intervertebral disc as a cushion sitting between the bodies of 2 vertebrae, and this cushion helps them move smoothly and to absorb shock. The cushion is made up of 2 parts, a tough outer layer called the annulus fibrosus and a soft gel-like center called the nucleus pulposus. Each cervical vertebra of the neck is small with a split in the back, bony wings on the sides, and holes for nerves. The atlas is different. It doesn't have a solid body, but has front and back arches and elongated wings. So that's this here, the atlas, C1. Then there's the axis, which has a peg-like structure sticking up, and it connects to the atlas, and this helps your neck to move more smoothly. Right? So we have atlas here, axis just under it. A typical thoracic vertebra is distinguished by a spike called the spinous process. That's these guys here. The spinous process reaches down and overlaps with the vertebra below it. On the sides of the thoracic vertebrae, there are these little spots called facets, like this one here. The facets are small flat areas where other bones can connect. And then also sticking out from the sides are these bony wings called transverse processes. So these guys here. This is where the ribs attach to the thoracic vertebrae. You can spot the transition from thoracic vertebrae to lumbar vertebrae by noting how it changes in shape and size. The last thoracic vertebra usually has a longer, more downward pointing spinous process, while the first lumbar vertebrae typically has a shorter and thicker process that's pointing more horizontally, like this. And these ones are pointing more horizontally. The sacrum is a single bone that is formed by 5 sacral vertebrae that have fused together. You can see lines running across the sacrum, and this is where the vertebrae have joined. At the back of the sacrum, the fused together bumps form what's called the medial sacral crest. You can see that here. And then on the sides, there are smaller bumps known as lateral sacral crests. Those guys are here. And those are formed from the fused transverse processes. The coccyx, or the tailbone, is made up of 4 tiny little vertebrae that have fused together. Disorders of the vertebral column can cause symptoms such as pain, weakness, and limited motion. For example, sometimes excessive bending or lifting can push the gel-like nucleus pulposa backward, causing a herniated disc. This can compress spinal nerves, leading to pain and weakness, commonly in the lower back or neck regions. Spinal stenosis, or narrowing of the spinal canal, can result in back and leg pain, numbness, weakness, or difficulty walking. Vertebral anomalies, pathology, or even obesity can lead to abnormal spinal curvature and conditions known as scoliosis, kyphosis, or lordosis. Scoliosis is an abnormal sideways curve, often requiring treatment with braces or surgery. Kyphosis is an excessive rounding of the upper back, leading to a hunched posture. It can be postural due to growth abnormalities, or it can be caused by conditions like osteoporosis. Lordosis is an excessive inward curve of the lower back, causing a sway back appearance. It can result from poor posture, obesity, or certain medical conditions, including pregnancy. Treatment includes therapy, exercise, bracing, or surgery in severe cases. Figure 7.30 shows how weakening of the annulus fibrosus can result in a herniated disc and compression of a spinal nerve, resulting in pain and or muscle weakness in the body regions supplied by that nerve. Figure 7.21 illustrates the 3 types of abnormal curvature of the vertebral column. Scoliosis, here on the left, is an abnormal lateral bend in the spine. The kyphosis is an excessive curvature of the upper thoracic vertebrae, and lordosis is the excessive curvature in the lumbar vertebrae. Other disorders of the spine include degenerative disc disease, fractures, sciatica, spinal cord injury, and ankylosing spondylitis. Degenerative disc disease is characterized by the gradual deterioration of spinal discs due to wear and tear, resulting in symptoms such as pain, stiffness, and reduced flexibility. Spinal fractures caused by trauma or medical conditions manifest with severe pain, difficulty moving, and potential nerve damage. Sciatica arises from the compression or irritation of the sciatic nerve by a herniated disc or bone spur, leading to pain, numbness, and tingling from the lower back down to the leg. Spinal cord injuries, typically caused by trauma, result in loss of sensation, paralysis, or impaired motor function. Ankylosing spondylitis, an inflammatory arthritis affecting the spine and sacroiliac joints, leads to stiffness, pain, and reduced mobility, worsening over time and potentially causing fusion of the vertebrae. The thoracic cage, also known as the rib cage, forms the chest portion of the body and consists of 12 pairs of ribs with costal cartilage and sternum. Figure 7.32 shows the sternum and the 12 pairs of ribs with their costal cartilages. The ribs are anchored posteriorly to the 12 thoracic vertebrae, and the sternum consists of the manubrium, body, and xiphoid process.
In your body, the framework of the chest is called the thoracic cage, or in common terminology, the rib cage. Its design functions to protect vital organs, such as your heart and lungs, and also provides points of attachment for many muscles. The thoracic or rib cage is comprised of three main parts: the sternum, the ribs, and the thoracic vertebrae. The sternum, also called the breastbone, is located in the middle of your chest, and it is composed of three parts. The manubrium is the widest part at the top of the bone, the body, located in the middle, and the xiphoid process at the bottom. There are a total of 12 ribs, and they originate on or between the thoracic vertebrae in the vertebral column, and they wrap around the sides of your body and end in the front of your body. Ribs 1 through 7 are called true ribs because they individually connect to the sternum by way of cartilaginous extensions called costal cartilages, which you can see here in this model. Ribs 8 through 12, located at the bottom of the rib cage, are called false ribs because they do not directly connect to the sternum from their own costal cartilages. Ribs 8 through 10 fuse with the costal cartilage of rib 7, and ribs 11 and 12 are called floating ribs because they do not connect with the sternum at all. The thoracic vertebrae make up the thoracic curvature in the vertebral column, as you can see here. Each of the 12 ribs articulate or form a joint with the corresponding vertebra. So, for example, rib 11 articulates with vertebra T11, and some of the ribs, such as rib 9, articulates with T9 and the vertebra above T8.
The sternum is like a long bone in the front of your chest, divided into three parts: the manubrium, the body, and xiphoid process. The manubrium is the wide top part and has a notch at the top where your collarbone connects. The body connects to the manubrium at a place called the sternal angle, which is important for identifying ribs. The xiphoid process is the bottom tip, which starts off as cartilage and hardens as you get older. Ribs are curved and flat bones that help form your chest wall. They connect to the thoracic vertebrae in your back, and most of them attach to the sternum in the front through cartilage. Each rib has different parts, including the head, neck, tubercle, body, angle, and a groove along the bottom for blood vessels and nerves. This figure helps to illustrate the parts of the ribs. The head is the back end that connects to the thoracic vertebrae. The neck is the narrow part next to the head. A tubercle is a bump on the back of the rib that connects to the vertebrae. The body is the main long part of the rib. The angle is where the rib curves the most. And the costal groove is a shallow groove along the bottom of the rib where blood vessels and nerves run. Rib classifications include true ribs, ribs 1 through 7, where costal cartilage attaches directly to the sternum. False ribs, ribs 8 through 12, have costal cartilage that doesn't attach directly to the sternum. Ribs 8 through 10 attach to the cartilage of the next higher rib. And then you have floating ribs, ribs 11 through 12. These are short ribs that do not attach to the sternum at all, and their costal cartilages terminate within the musculature of the lateral abdominal wall. The development of the axial skeleton starts early in the embryo and keeps growing and changing for many years after birth. It all begins around week 3 of pregnancy when the notochord appears, leading to the formation of the neural tube by week 4. Special tissues called somites start forming from mesoderm tissue. Among these, sclerotomes are the parts that grow into connective tissues, cartilage, and bones. Skull bones grow in two ways. You have the intramembranous and endochondral ossification. Fontanelles, those soft spots that you feel on a baby's head, are essential for birth because they allow the skull to grow after birth. The skull and the brain keep growing. Figure 7.33 shows how the bones of the newborn skull are not fully ossified, and they're separated by large areas called fontanelles, which are filled with fibrous connective tissue. The fontanelles allow for continued growth of the skull and the brain after birth. At the time of birth, the facial bones are very small and underdeveloped, and the mastoid process has not yet formed. Let's have a look here of the bones and fontanelles and processes of the baby's skull.
Here we see a neonatal skull, as we might see in a newborn baby or a full-term fetus. Again, we see the facial bones and the cranial bones. Mandible, maxilla, nasal bone, nasal cavities, orbital cavities for the eyes, zygomatic bones. That's actually a bit of sphenoid bone you can see there. temporal bones. Well, that's one temporal bone, there's another one on the other side. Parietal bones here, the larger bones on the side, and of course the occipital bone at the back. And as we would expect, the foramen magnum, where the spinal cord would lie here, where my finger is, connecting with the medulla oblongata within the cranial cavity. We notice on the neonatal skull the frontal bones are not yet ossified into a single bone. But maybe the main thing we notice about the neonatal skull is the presence of the fontanelles, these gaps in the bones here. Now, these are made of cartilaginous sheets that resemble membranes. They're actually membranes of mesenchyme. They will ossify in time, of course, but let's just notice the anatomical names of these first of all. Here we have the large anterior fontanelle. Sometimes these are called soft spots on the top of the baby's head. And at the back, we notice the posterior fontanelle. At the front and the side here, we have the anterolateral fontanelle. The anterolateral fontanelle. Coming down here, we notice the posterolateral fontanelle. And of course there's another posterolateral fontanelle on the other side, and another anterolateral fontanelle on the right side. The presence of these fontanelles and the cartilaginous tissue allows for flexibility during birth as the fetal head passes down through the birth canal. And they also allow for the rapid growth of the brain that happens in the first 2 years of life.
As babies grow, the fontanelles get smaller and disappear by the time they're about 2 years old. The skull continues to grow and form sutures, which are strong fibrous tissues. The facial bones and the floor of the brain case develop through endochondral ossification. When babies are born, bones like the maxilla, mandible, and paranasal sinuses are still not fully developed, but as the child continues to grow into adulthood, various things happen, such as the mastoid process getting bigger, the mandible and frontal bone fuse together, the paranasal sinuses get larger, and the jaw expands. Craniosynostosis happens when a suture line in a baby's skull closes too early, affecting skull growth and brain growth as well. This is a pretty rare condition. It occurs in about 1 out of 2,000 births. It's more common in boys. And there are 2 types. Primary, which involves the early fusion of one suture leading to an abnormal head shape, like a long, narrow head, or you could have complex, which results from the premature fusion of multiple sutures, and this severely limits skull and brain growth. Treatment usually involves surgery to open the fused sutures and allow normal skull growth to occur. The earlier the surgery, the better the outcome. Most children treated this way go on to develop normally without any problems with their nervous system later in life. This figure is a visualization of craniosynostosis showing abnormal skull shape due to premature fusion of cranial sutures either just before birth or shortly thereafter. In this condition, the bones of the skull can't grow quickly enough to keep up with the growing brain, resulting in increased pressure inside the skull. If craniosynostosis is not treated quickly, it can result in a loss of vision, hearing problems, chronic headaches, and other nervous disorders. As we briefly discussed before, the embryonic development of the spine and rib cage starts with the notochord. The notochord is a flexible rod-like structure found in the embryos of all chordates, all animals that have backbones, and it helps to define the basic body plan as the embryo is developing. Mesenchyme, a type of embryonic connective tissue made up of undifferentiated cells, surrounds the notochord and begins forming cartilage models that eventually turn into bone via endochondral ossification. While this is happening, the notochord stays in between the developing vertebrae, helping to create the intervertebral discs. Ribs initially grow as part of the cartilage model for each vertebra, but as they develop, they separate and take their place in the chest. As for the sternum, it begins as a model made of hyaline cartilage. The top part, the manubrium, and the main body portion become bone first, and then the bottom part, the xiphoid process, remains cartilaginous until later in life, until about 20 to 25 years of age. Thank you guys for watching. Don't forget to do the reading. Check the description for more videos related to these topics, and leave your questions for me in the comments below.